afternoon, everyone, and welcome to today's webinar presentation on implementing smoking rooms in supervised consumption sites and key lessons learned from our panelists today. My name is Pamela Leese, and I'm a public health physician at Public Health Ontario, and I have the pleasure to be a moderator for today's session. We're really grateful for the partnership and support from the Ontario Network of People Who Use Drugs and Toronto Public Health and all of our speakers today, and looking forward to the conversation. Before we begin with today's presentation, I'll mention a few housekeeping items. To enhance the presentation experience, the chat pod and raise hand features are enabled. So we encourage the participants to submit content questions through the chat pod, and that's at the bottom of your screen. Additionally, you can use the hands up feature to ask questions verbally during the discussion period. Please note that the session is being recorded. The edited version of the final recording will be available afterwards. And if at any point during the session you experience any technical issues, you can email capacitybuilding@oahpp.ca. So just on the next slide, please, Caroline, thanks. Before we begin, we'll have our acknowledgements. So we acknowledge the land that we're meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis people. We're committed to reconciliation and building meaningful relationships through seeking mutually beneficial partnerships, taking the lead from Indigenous communities, and being accountable and transparent in our work. We also recognize the strengths, expertise, and innovation and leadership of people who use drugs, and this has been critical in developing and implementing programs and services in harm reduction and the response to the overdose crisis. And we have the partnership today with the Ontario Network of People Who Use Drugs, and Nat and Ashley joining in the conversation. And so grateful for your partnership. We want to encourage, open and supportive discussion and a safer space for everyone in the discussion today. Just to look at the agenda for a moment before I pass it over, we'll have the opening from ONPUT, the presentations and panel discussion over 30 minutes, and then we'll have 15 minutes for Q&A, and we'll wrap up including a reflection from Ashley with ONPUT. So I will it's my pleasure really to introduce Mark, who will do the introductions for the rest of our panel. Mark Gaspar is a Policy Development Officer with the Toronto Drug Strategy at Toronto Public Health, and he'll be facilitating the panel. So over to you, Mark.
Thank you so much, Pamela. Thank you everybody for attending today. We have a great set of speakers. So I'll introduce them quickly. So we have Nat Kaminsky from the region of Peel, where they work in harm reduction and founded the Peel Drug Users Network. They have lived experience with poverty and systemic violence, being a person who uses drugs, engaged in sex work, and has a history of incarceration. Then we have Casey Shapel, who's currently the harm reduction coordinator at Casey House and has worked in harm reduction for over a decade in both Australia and Canada. Then we have Jill Alhus, who's a program manager at Blood Ties for Direction Center in Whitehorse, Yukon, who supports the supervised consumption site, housing programs, drop-in centers, and wellness programs, needle and pipe programs, and mobile outreach vans. Then we have Kayla D. Mong, who's the executive director for Prairie Harm Reduction in Saskatoon. Kayla has been with Prairie Harm Reduction for the last 10 years, working with families, youth, and individuals, advocating for the better treatment of people who use substances. And finally, Ashley Smoke is an Indigenous Two-Spirit parent who uses drugs. Ashley co-founded the Ontario Network of People Who Use Drugs, sitting on the board as secretary, as well as working for the Women HIV/AIDS Initiative of Ontario. And full bios will be in the chat, but really excited to have a chat with this group. But I'll pass it off to Nat to get us started.
Thank you. Before I begin, I would like to acknowledge that the land I'm presenting from today in Milton, Ontario is part of Treaty 13A, the head of the Lake Treaty. And these lands are the traditional lands of the Anishinaabeg, Haudenosaunee, the Attawandarock, and the Mississaugas of the Credit. So as introduced, my name is Nat Kaminsky, and I'm the president of the Ontario Network of People Who Use Drugs. ONPID is a provincial association with a large and diverse membership of persons with lived and living expertise who work on multidisciplinary teams to inform and shape drug policy. Some of the work is in collaboration and partnership with Public Health Ontario, supporting sessions like the one we are at today, to ensure the voices of people who use drugs are present where their lives are discussed. Beyond my work with ONPID, I am also a harm reduction outreach and peer program supervisor at Moyo Health and Community Services. And through that work, I support people who use drugs in peer roles to deliver harm reduction education and supplies into the community. All of that is to say, as a person who identifies as a person who uses drugs and advocates for drug policy reform, and supports people who use drugs in the community, I felt it was important to center our conversations on the environment we are all working in today. I started in this field in early 2013, and prior to that, I was actively using heroin for years. Harm reduction was very different, and strategies being shared included you could always do more, but you can't do less. Consider switching consumption methods from injection to inhalation to protect your veins, and try smoking a small amount to test the strength of your dope before preparing your shot. All that to say that back in the days of heroin, these tips were very helpful for folks who were injection users. But heroin disappeared, fentanyl entered the supply, and harm reduction programs did what they could to support people who use drugs. We fought for foils for inhalation services and began distributing the harm reduction materials we saw communities requiring. As a harm reduction worker, I remember handing out injection kits and providing foil kits to folks so they could use multiple methods for consumption. And communities shifted their consumption methods. Maybe it was the supplies that were finally available. Maybe it was because we believed smoking was safer than injections, which in many ways it was, but not on overdose risk. Or maybe it was because the drugs were more expensive, tolerances grew quickly, and withdrawals set in quicker. And so smoking stretched out the drugs. Or maybe it was that all those things were combined. Regardless, we now see people who use fentanyl, use it via inhalation, and therefore providing consumption and treatment services, which exclude inhalation, keeps a large portion of the opiate using population from having access to life-saving services. And let's not forget, beyond opiate consumption, we're also seeing an increase in meth use and crack. So where do those folks go if they can't come inside? People who use drugs often use more than one drug as well. So people who use drugs often use more than one drug as well. So are we really serving folks if for one substance they can come in and for another they cannot? Services and supports need to be inclusive. They need to be brave and they need to be creative. But more than that, they need to really push back if they believe that people who use drugs deserve the right to use those drugs. People who use drugs are continuing to die in stairwells, in bathrooms, in shelters, and in apartments alone. So how do we bring them in? Inhalation services are a great place to start. We have seen a crack contamination. We have seen drug screens that now suggest contamination is the standard for our unregulated market. And we know overdoses from inhalation are complex and continue to rise. The Ontario Network of People Who Use Drugs believes anyone who uses drugs should be able to do so without being criminalized and without having to risk their lives to do so. People who use drugs help build the many models harm reduction programs are funded for, and yet we cannot access them. Consumption and treatment services should serve all forms of drug use, all forms of drugs, and all forms of consumption. We applaud the folks presenting today who have provided us just that. Thank you, Mark.
Thanks, Nat. Thanks for setting us up fantastically and for really clarifying why we need these services, and for thanking our wonderful panelists who have been doing the work of setting these services up across Canada so that we could think about how exactly do we do it in our local region, what are the best practices, what are the ways to implement this effectively. So with our panelists, I could start with the first question, which is briefly describing your role and what services your organization offers when it comes to supervised smoking. So I'll pass it off to Casey to begin.
Thanks, Mark. Hi, everyone. My name's Casey Sheeple. As mentioned, I'm a harm reduction coordinator at Casey House. The name is just a coincidence. I oversee supervised consumption services and harm reduction programming here. My pronouns are he and him, and you've probably noticed that I've got a bit of an accent, so I'll try and talk slowly, but we'll see how it goes. So in terms of Casey House, so we're a small specialty hospital in downtown Toronto on Treaty 13 land. For people living with or at risk of HIV, we have a 14-bed inpatient unit and an outpatient program with a nursing clinic and allied health services. We have supervised consumption booths on both our inpatient and outpatient spaces, and our outpatient supervised consumption site is open Monday to Friday, 10 a.m. till 4 p.m. And for inpatient clients, there is one booth available 24/7 right on the unit. Since November last year, we made inhalation of unregulated substances available in one of our booths. And we also provide a range of safer inhalation kits 24/7 for clients and community members. Thanks.
Terrific. I'll pass it over to you, Kayla.
Hello, everybody. My name is Kayla. I am the Executive Director for Prairie Harm Reduction in Saskatoon. I will apologize. I'm on the tail end of what has turned out to be a horrible illness. I'm just getting my voice back after going away for a week, so I apologize for how I sound. Prairie Harm Reduction, we've been around since 1986. We were previously known as AIDS Saskatoon. We changed our name in 2019 and moved to a new building with the goal of opening our safe consumption site, and had the privilege of building our building or renovating our building around the HVAC system for an inhalation room. Inhalation services were part of our initial plan. They weren't something that we came in and did afterwards. And like I said, we had the privilege of creating the whole program around having this inhalation space available. We modeled ours after what was created in Lethbridge initially. We are quite well known across the country for being a safe consumption site that is completely unfunded and operates solely off of donations and sales of our merchandise line. In addition to the safe consumption site, we operate a variety of services in Saskatoon, targeting individuals, families, and youth, all focused around harm reduction and engaging people who use substances in services where they are respected and honored and are able to access services for however that looks like for them without any coercion and manipulation. I'll stop there for now.
Thank you. I'll pass it over to Jill.
Hi, everyone. My name is Jill Alhus. I use she, her pronouns. I am the program manager at Blood Ties for Direction Center. We're a harm reduction organization located on the traditional territory of the Kwanlin Dun First Nation and Ta'an Council in what is colonially known as Whitehorse, Yukon. I manage and support many of our frontline programs, including our supervised consumption site, which we opened in 2021. And I was part of the initial planning and implementation of the program. We provide a safe place for people to consume their drugs by injection, snorting, oral consumption, or inhalation. We also have an FTIR and do drug checking services out of that space. And our supervised consumption site is co-located in a building with the other services that Blood Ties offers, including our drop-in center, wellness and housing programs, needle and pipe program, and education and prevention programs. We currently have 3 tables in our smoking room, so the equivalent of 3 booths without the dividers between them, and 5 injection/consumption booths. Our site's currently open from 12 p.m. to 9 p.m., although we've applied for funding to extend to weekends. Our staffing model is small. We have 2 full-time staff, 2 peer support workers with lived experience, 1 team lead, and I guess I fill in some of the gaps. It's a partnership with the Yukon government, so we have healthcare provision on site intermittently through the government, and we really drew heavily on the learnings of prairie harm reduction, and we're really grateful to them when we opened our space. We also consulted with our lived experience advisory committee, and they provided us with some really helpful feedback on our chill out space and our layout and how we could do a good job of operating the service. We also did a number of tours and surveys with people who use drugs that were instrumental in how we enrolled the program. Yeah, and I'll leave it at that for now.
Thank you. So we have 2 questions. We'll start with question 1, but just to lay it out for everybody, the first set of questions is, what were the key lessons and barriers encountered when implementing the site? We've heard a little bit about that, but what was the, before it was operational, what were the things that we had to learn? And I see a message from the audience, a question already asking about protecting workers, particularly the concern with secondhand smoke. So that's something we could speak to in setting up the site. And then later on, we're going to ask a question. We'll go back around. What are we learning from the day-to-day operations and upkeep of the site? So we'll begin with question 1, and we'll start with Casey again about key learnings from implementing the site, and specifically implementing the site in Toronto and Ontario, and all the learnings from that.
Thanks, Mark. So I guess in terms of setting up the space, there were 3 categories, I guess, of key lessons: client engagement, physical structure and location, and air testing. So in terms of client engagement, as part of our planning, we engaged with people who use substances in a few different ways. So I interviewed inpatient and outpatient clients who use drugs, as well as community members in our neighborhood. We also led a research project called the Engage with Harm Reduction Study. As part of that, an advisory group was created, which led to the establishment of 12 principles for client-informed supervised consumption. We really benefited a lot from these consultations prior to construction, and one of the consistent messages for us was the need for inhalation. So I guess because we were a newer site, we started with construction of inhalation right from the get-go. We weren't able to offer inhalation straight off the bat, but that didn't stop us from offering supervised consumption. So we opened our inpatient unit, SCS, in August 2021, and our outpatient site in April 2022. In October 2022, so last year, we received confirmation from the Ministry of Health that operating the safer inhalation on site wouldn't contravene the Smoke-Free Ontario Act. So when we opened the inhalation site in November, the response from our community was a lot of excitement. In terms of physical structure and location, the physical structure was already there, and we needed to confirm aspects of the infrastructure. So we had an air balancing company inspect the HVAC that we already had to see if our existing system could support the extraction of smoke from the room. Because our building was constructed in 2017, the system was recent, and so we had a suitable HVAC already. The space we chose was near a washroom with an isolated exhaust ducting that ran across the ceiling and expelled through the roof. So we adapted that to extract air from the inhalation booth. I should mention as well, we have 3 booths in our outpatient site, 2 are for eating, snorting, injection, and the 3rd booth is for inhalation. And so it's a separate booth with a door to close. Other learnings, we opted to have the booth that was facing an exterior wall become our inhalation booth, so that it was easy to drill a hole inside the wall to be able to have the fumes extracted directly from the booth to outside. In terms of air testing, it took us a lot of time to find the right way of testing. So initially we used a conventional method for fire code testing. We filled the entire room with smoke and tested the purge capacity, and it took 7 minutes to clear. But we realized that wasn't actually a realistic test of what smoke or fumes produced from inhaling drugs would look like, nor was 7 minutes a reasonable time to respond to overdose. So our HVAC technicians actually scaled down and lit a smaller item that more closely replicated the amount of smoke produced by a substance, and we used something that was very similar to a candle. With this level of test, it was determined that the purge capacity of our fan was really good. It closely emulates outdoor airflow. Because we are not funded by an Ontario CTS program, we have been able to open the SCS with donor funding. So I guess just to summarize, we consulted with clients, consulted with HVAC technicians, and did a lot of work and training with staff. And I'll leave it at that for now.
Thank you so much, Casey. I'll move it over to Kayla, and a question I see coming up in the chat is the rate of air exchange. How much does the room have to flow in a given hour, and how quickly, in case of emergency, I'm responding to overdose. So if you have those stats, that would be great.
Yeah, thank you very much. Our preparation started about 5 years before we actually opened the site. In that time, it became clear in our community that inhalation was a key point of that, as we were dealing with high usage of crystal meth and seeing an ever increasing population of people using crystal meth who were accessing our needle exchange at the time and really interested in engaging in services further. We did 3 years of drug user surveys, worked with our fire and police department and our local health authority at the time to look at heat maps around HIV transmission, discarded syringes, crime rates in different communities, and what we were seeing for overdoses at the time. When we started planning this, we were not seeing a high number of overdoses in our community. The driving factor behind the safe consumption site was actually around HIV transmission. Saskatchewan's been leading the country in HIV transmission for over a decade, with about 2 times the national average of transmission, with our highest risk population being people that use substances. So we were really focused on how to engage that population and decrease the number of HIV transmissions we were seeing in our community. It took us about 2 years to find the right building. We were looking at a very specific location where those heat maps showed us that that was kind of ground zero for HIV transmissions, for overdoses, and where the people already were. Which we thought was very important. We didn't want to create a site that required people to come to us. We wanted to build a site where people already were. Like I said before, our whole building was built around our HVAC system. Our building's divided into 2 areas. One is a drop-in center and support building, and one is a safe consumption site. Our HVAC system at our safe consumption site runs on a rapid air exchange system. We have 7 booths that have high rate exhaust fans over every booth. And then our inhalation room, which is about a 4x6 area room with a door that runs on an HVAC system that is a higher rate of exchange. I don't know how many per hour it is, but it runs on an independent air exchange system. We do have an emergency function. So if staff need to get in there and there's a concern about air quality, we do have an emergency button that can be hit, and the air is exchanged in 30 seconds, which allows staff to get in there quickly. At this point, we allow 3 people in that room at a time. We try and keep it to 3 people that are using the same type of substances, just to kind of mitigate, cross usage where people don't want it. But the whole entire site, like I said, we had the privilege of building the building around it. And so we were able to take a lot of time and thought around how it was created and the way it was set up, and using a lot of feedback from the people that were accessing services and the people that were going to engage in these services. When I looked at our 2022 stats, our inhalation room accounts for about 25% of usage for the space. So that equals about just over 1,200 visits last year to our inhalation space. And we saw quite an increase in the later part of the year. So we're seeing more people who are knowingly using fentanyl choosing to smoke it here. And so our stats increased in the last quarter of last year. So I will stop there. Thank you.
Thank you. I'll pass it over to Jill, some of the implementation learnings.
Sorry about that. So yeah, the supervised consumption site in the Yukon started in a bit of a unique way. People who use drugs had been advocating for supervised consumption for many years, but in the most recent territorial election in 2021, the NDP and the Liberal Party formed a coalition government based on an agreement. And one of the stipulations of the agreement was to open a supervised consumption within 4 months. Negotiations for us to partner on the site took 4 months, and we were able to get a 1-month extension, but that meant we only had 1 month to get up and running with the site. And we only got into the space for 72 hours before we did community tours there. So this meant that there was a really tight timeline for us. We weren't unfortunately able to get inhalation up and running right when the site opened, but we were able to open for injection and other forms of consumption than smoking. We had sort of a tricky time hiring for the site initially when it opened. We needed to get policies in place, community engagement, an exemption to indoor bylaw. And some lessons we learned were we negotiated on the space, and one of the key aspects of our negotiation was that we would only participate if there was an inhalation room. We were able to use kit distribution stats to back up that rationale to the Yukon government who fund the site. We also wanted to collate the rest of our organization in the same building, and we were really lucky to be offered what used to be an extended care home, which had quite a bit of outfitting and infrastructure that we could repurpose for our site. We hired a peer consultant who had experience accessing other sites to review the policy and the space to provide feedback, which was super helpful because there are no supervised consumption sites, or there weren't any before this site opened. So it was really valuable to have someone with lived experience who had also accessed sites to provide us with input. We did community engagement events. They were very challenging in person. The community tours were quite positive and went really well. Also, the moderated Zoom sessions worked really well. So I guess that's a lesson learned, is that putting people in a room to ask questions from the Downtown Residents Association was a bit more challenging in terms of being very polarizing. The filtration and exhaust system was a challenge to implement. There's a shortage of local contractors and local expertise, and also supply chain and demand delays. We were able to use an accessible washroom that's basically a cube, 8 feet by 8 feet by 8 feet, that was repurposed into the smoking room. We installed a glass window on it and a pretty extensive exhaust system, which I can read the stats for. It has 3 flow rates. The first one is just like a very good HRV system for the entire supervised consumption space that was installed for that purpose, with makeup airflow that comes in. There's also, when the exhaust system is on, it is isolated from the rest of the space with high exhaust fans above the injection booths as well. When the system is on, the in-floor HRV return air duct damper closes and the exhaust fan starts operating kind of like independently. The flow rate is 184 CFM. So I don't know what that works out. I don't know enough about the technical specs to know what that works out to hourly. But when the emergency purge switch is activated, the damper closes between the exhaust fans over the injection area and focuses entirely on the smoking room, and the fan increases to 309.5 CFM. We hired a contractor to determine how long smoke took to clear using handheld smoke tubes, which were like sealed glass tubes that when broken created smoke. It visually cleared within 14 seconds, but the purge function takes 15 seconds to turn on. So we have a 30-second wait time before we enter the room, which provides staff with enough time to get oxygen. And we do require PPE in the form of masks. And I think those are the main learnings for, implementation.
Thank you. And I see a lot of wonderful questions coming up that we'll get to in a moment. So our next question is the day-to-day operations. What have been the key learnings, gaps, opportunities now that this is running? And I'll just switch the order. So Kayla, do you wanna start?
Sure. I think one of our key challenges and learnings has been because we are not funded, and we rely very heavily on our local businesses and community members for funding, which has meant that our hours over the last couple of years have been not, I don't want to say inconsistent, but we've had to adapt them and change them according to the flow of donations coming in, which is quite difficult and quite stressful on the population that are accessing services. We have a lot of people who are very, very invested in using the site and rely on the site very, very heavily and plan their day around it. And so, not being able to accommodate all of their needs has been very difficult. Our goal is still 24/7 operations. We are still working towards that, but it is, very difficult in the political climate that we have. We are very well supported locally by our municipal government, by our chief of police and our chief of fire. But our provincial government is very vocally against the site, as well as our local tribal council. So that has been extremely challenging.
Thank you for that. Jill, do you want to talk a bit about day-to-day operations?
For sure. So our smoking room opened in May 2022. Our uptake in our program skyrocketed after that. 93% of consumptions that occur at our site are through inhalation. So we do not need 5 booths, which we kind of figured inhalation is the primary mode of use in the Yukon. The room setup and space design, I guess, was like kind of a key category where we have learned a lot. Having a peer consultant look at the space helped because even as the site had operated, they were able to provide us with a lot of input on things we hadn't thought about. Our Lived Experience Advisory Committee also provided some important information. The exhaust system is very loud, so we've installed soundproofing panels throughout the space, and we blast a radio in the room. And we had some complaints about noise initially, but folks seem pretty content with the radio being pretty loud, and we can't hear all that much with the door closed in the room. So it's primarily very loud for folks that are in the smoking room. The visibility for staff to supervise people in the smoking room was challenging, even with having a glass window. it kind of is tricky to see sort of in some of the corners of the space. So we're looking into installing mirrors just to provide a little more visibility. So that's something I wish we had thought about up front. The open concept design was necessary for us for having a small staffing team. The minimum amount of staff to have the site open is 2, and it is often the case that we're operating with 2 or 3 staff working, and that means that we couldn't have like 3 different rooms where folks were in. And we have primarily the space has like a washroom, our smoking room, and then our chill out space and our main consumption area is in one giant room, which is the entryway to the space. So this sort of means that it's hard to ensure privacy of people consuming drugs, even with privacy screens, because people entering the space can walk over onto the other side, and ensuring safety for people in the smoking room has been challenging because we can't hear what's happening. And some folks have reported having other folks threatening them or pressuring them to share drugs while in the smoking room. So we have implemented policy around that so that if folks want to consume independently or they want to make sure they're not consuming with another individual, we can accommodate that. We also moved our check-in desk to kind of act as a separation between the space. And we're looking into installing fobs on the door of the smoking room to ensure privacy and safety for people smoking. More of a divide would be helpful, but we would need to significantly increase our staffing model. Ideally, another smoking room would be great, but we would also need a larger staff team to manage. So we're making it work even with a really small team. The time limits on the smoking room were a little bit hard because initially we implemented too long of a time limit, 20 minutes, 40 if no one was waiting, and moving people along was harder. One of the main reasons for the limit is to ensure that the space is available without too long of a wait time for folks using opioids. So changing the four months into operation to 10 minutes was challenging. And if I could go back in time, I would set a lower limit starting at the beginning. We do remind people they can come back as often as they'd like, and most people kind of are in and out of the smoking room and the chill out space. We're considering having a pull tab system like at a blood lab so that people can like have a sense of how long their wait still is and know that we haven't forgotten them while they're waiting. The government hasn't been able to provide us with healthcare providers in the way that we were initially intending to. And because of that, we had all of our staff trained in basic life support and oxygen administration, which has been critical to operating the space. We also redeployed existing staff to the program initially to help build trust in the community, and that worked really well as well. And people wanted to smoke outside in the summer, so that was a challenge because we couldn't provide the same protections for folks. And if we had a larger space, I would have implemented like a tent or something outside for the summer. So if that's a capability for folks looking into these programs, I think that would be something to think about.
Thank you so much, Jill. And Casey, I know it's only been running for a little bit, but learnings from the day-to-day operations.
For sure. Yeah, so I guess we've only been open less than 3 months, so probably don't have as many lessons to contribute. I will say, I just want to shout out both Prairie and Blood Ties, because I think we learned a lot from both of your organizations as well in the lead up to launching ours. So I think for us, just within the first few weeks, a key lesson for us was really around educating people around what can be smoked in the booth and what can't. I guess, yeah, one lesson would be just to consider as part of the testing process to consider where people are in relation to the extractor fan, because our fan is so strong. I definitely would have started with testing with different types of lighters and matches and to see how the airflow affects the flame. Since opening the inhalation booth for us, about half of our consumption visits are now inhalation. So I think it was a really important lesson in knowing, like listening to what the people in your population really want. I'll leave it at that.
Terrific. Thank you so much. So now we're going to go into the Q&A. People can raise their, and let me know if there are any internet issues or if you can hear me properly. So people could put their hands up and I could ask you to speak. And we have some questions already in the chat that I will try to get to. If I've forgotten one, please just resubmit. All right, so I have one question here, and this could go out to any of the speakers, so whoever wants to chime in. Can you share the rationale of having multiple people using the inhalation room at the same time? Also, any challenges and benefits to this?
I can speak to that first, I suppose. For us, one of the rationales is that we often have wait times for the smoking room that can get really long during busy periods. So having just one person in the smoking room would mean people were waiting like an hour to use the space, which we would lose a lot of folks that way. We also find that it's a very social, like crack is the primary substance. People are smoking there as well as opioids, and it's a very social method of use. Smoking, and people really want to be in there together. And that we find that was a key part of people feeling comfortable accessing the space. So I think if we limited it to one person, we would lose a lot of folks, especially folks that like to use with their partners in the space. We do limit it if people we try to have open conversations with people to make sure they know that if they wanted to consume alone in the room, we would accommodate that. And we do have a few folks that have people that they don't want to consume with, but it's been maybe a little bit challenging to manage the odd situation with somebody, but overall, it's worked really well, and we've had really good feedback on it.
Thanks, Jill. So there's one question here. Are you aware of data on occupational exposures at supervised inhalation sites? And there are a few questions, I'll kind of bring them together broadly about how ensuring staff safety and PPE, or even just the emergency buttons. So speaking a little bit to that, whoever wants to start.
I do know that WorkSafe BC has done a lot of work on air quality and safe consumption sites. I've met with them a few times as they've been going through and looking at inhalation spaces. They have quite a collection of data, far more than I've seen anywhere else in the country. Our staff are masked. They use level 3 masks. We haven't seen a lot of issues around, we don't require them to wear gloves when they're in this space or anything. No other PPE other than the masking. So that's, really our big staff safety thing. We find that people move really freely throughout the space and are kind of back and forth. So, and haven't had any issues with air quality or staff safety.
Terrific. Anything to add, Jill, Casey, from?
I think we went a bit overkill when we did our assessment. We hired a contractor who produced more smoke than would be produced from folks smoking. And it was definitely a concern, but there's no visible smoke when the site's running. And just with the makeup air, I think from what the contractor told us, there's negligible, if no risk to people, even if staff were in there while folks were smoking, and they're not. So I think, I have asthma, and I'm very sensitive to smoke, and I've never smelled anything in there. The fan is extremely powerful and effective in maintaining probably superior air quality to the rest of our building.
Is there, sticking with this line of questioning, is there any specific design standard that was referenced, or was it just working with the contractor and figuring out and doing these tests?
For us, we couldn't find any existing data. So I think that was one of the delays in opening the program, was not having a standard to reference, although Prairie Harm Reduction were very helpful. So hopefully moving forward, there will be guidelines that can be used. I think that would have expedited the process for us.
Yeah, we took the drawings from Lethbridge, like they send us all the makeups for their HVAC system. And we took it to our HVAC company and said, what can we do, or what does this look like? Our system was custom built in consultation with our HVAC system and an engineer. But yeah, I think standardized documentation on this is really, really helpful. We get a lot of requests for our drawings. I send them to whoever asks. There's no restrictions on that. And the Dr. Peter Center has all of our stuff as well and distributes it out. But yeah, standardized kind of baseline information for people to access would be really helpful.
Terrific. Another question, what was the participant or client response to the HVAC ventilation system noise at the different sites?
Ours isn't that noisy, like it sounds like a fan running. And so nobody ever comments on it. We have some pretty loud gangster rap that plays all day in that site. So I don't think people even notice that the fan is on at all. And the fan in the inhalation space itself is actually quieter than in our larger space.
Yeah, like I mentioned before, I think our system is a bit beyond what's needed for the size of our room. So it is a bit loud, but we have soundproofing panels throughout the space that help dampen the sound. And we also blare music in the smoking room, which people can change to whatever they want. And people seem to not have any complaints about noise.
Excellent. I was going to ask how people chose music, the music of their choice, and there's the option. Another question, at 184 and 309 CFM, so this is a technical question, that capture velocity, does that capture velocity the face of the capture devices? Do you know the setback distance between the capture hood and the source generation? So I think this is going to Jill. That's a very specific.
Yeah. I'm not sure if this will answer perfectly, but you're welcome to contact me and I can make sure I have the accurate information for you. The makeup air vents are in the floor of the space below one of the booths, and the test that we did was visual clearance from the floor and then also from where the booth would be, from the furthest corner of the space to the exhaust system. And yeah, the CFM would be from anyway, I can give you more specific text. I'm struggling a bit with some of the technical language. I would have to look it up, but I know that it was, it's about an 8 foot by 8 foot by 8 foot room. So it's about 8 feet from the makeup air duct, maybe 10 feet with the distance to the exhaust system.
Excellent. Another question. There's discussion at some municipal and regional district levels that the smoking of illicit drugs included in clean air smoke-free bylaws, which currently only apply to non-controlled substances within the meaning of the Controlled Drugs and Substances Act. Did you encounter this perspective, and can you share any strategies you use to address this?
We had no municipal issues or barriers put in our place right from the beginning of the planning of the implementation of the site. We were in constant work with our mayor and some city officials around what this looked like. And they were in very strong support of the site. And so they weren't working to put any extra barriers in place. I know there are places that are now dealing with municipal barriers being put in place for sites, which is really unfortunate. I'm hearing a lot from Ontario specifically around this. We had tons of support, and so our municipal government was not, they actively did not put any barriers in place for us. And then with our federal exemption, it's just part of our exemption is the inhalation space and the substances that can be used. All we were to have been told from our municipal government is people cannot smoke marijuana or tobacco in there because of the municipal bylaws on those specifically.
Yeah, we have a territory-wide indoor smoking law, and we did go through some processes to ensure that smoking illicit substances was exempt. And we were able to clarify that, although it's similarly, people cannot smoke cannabis or tobacco in the room.
We had one question. Thanks for that, Joe. We had one question about if we could get a list of the HVAC systems people are working with. I know, Kayla, you said that you are happy to hand out. So I think everybody here is happy to share their specs. And with this last question, some audience members are asking how the smoking of tobacco, and I'll add cannabis potentially into this, how that's dealt with, since that technically wouldn't be allowed or crosses other bylaws, if you're noticing this being an issue.
I can jump in with that one. Oh. Okay. Clearly our HVAC runs a lot better than our internet system here. Hopefully I'm not freezing right now. For us, it took a lot of unanticipated education right up front, especially for folks who were admitted to the inpatient unit who, we opened our inhalation booth right at the beginning of the seasonal change to winter as well. So I think obviously a lot of people wanted to come in and smoke tobacco and cannabis understandably inside somewhere. Education and explaining what the booth is for, what can be used in there and what can't.
Terrific. Thank you, Casey.
There would be multiple hour wait times if people could smoke cannabis and cigarettes in our space. So we have signs that's basically, we tell people you can't smoke anything that's legal in the space, because there are lots of spaces for that, including alcohol. So we have smoking areas outside and folks can go and smoke up there, and they do.
Thanks, Jill. So first I want to thank you all for this discussion, for both the discussion and for doing the groundwork for us. It's just incredible. And I want to pass it over to Ashley to give some closing reflections.
So here we're in a rural area, so we've had to fill the gaps that safe consumption services can't fill with unsanctioned sites in various parts of the region, filling gaps without funding because we're left out because of barriers and protocols designed to keep us from getting funding. As people who use drugs, our ideas are often used to get programs funded and sites, but then we often just get honorariums and stuff. So I think it's important to acknowledge the local groups too that aren't funded or aren't able to get sites up and running or running unsanctioned sites. So in Peterborough here, there's a site called the Tweak Easy, and then there's a new one in Coburg. We get crowdfunding as well, but I think it came much out of the same ways that everyone here started. People who were using drugs were dying because they were smoking, and they weren't allowed to go to sites because of the way that they use their drugs. So I think we were tired of our friends dying, so we kind of decided to fill those gaps. But it's not easy. because we have to watch people who smoke be at risk of overdose due to government inaction and unwillingness to change the status quo to save lives and getting burnt out. And I think last week here we had over 10 fatal overdoses in the surrounding area, and 7 happened in an area where there's a CTS, all because people are smoking and not injecting and aren't allowed to use a CTS. So I think that it's so important to fill the gaps and allow people who use drugs to have a voice and to lead some of these movements and to fund people who use drugs to do some of this work. I think that's so important. And yeah, like we know what we need, and we should be the ones to determine what sites look like, how services are implemented, and who works at a site. People who use drugs and the people who use the site should govern all those things. And for Casey House, I think like having an inpatient booth, it's so necessary, but like they said, they have one, and that's probably not enough, right? Like smoking laws felt more important. Like I was paying attention to a lot of the stuff that Casey House went through. And I think that it felt like the smoking laws were more important than our lives, and like the barriers and all the requirements that were necessary felt like purposeful and like reinforce the stigma that we feel every day, and we're told day after day we're not as important as the processes that the government has. And what Casey House went through kind of proved to us people who use drugs that like we were right to feel like that. So I'm glad that it's finally open and everything's going good, and I hope that there's more funding coming so you can get more booths and for inpatients. But yeah, prairie harm reduction, the inhalation as like the initial plan is something that I think is like genius. Not often people like think about opening sites instead of like thinking about the people who are most marginalized from those sites and then addressing those needs. So I commend you for focusing on like the inhalation aspect. And the groups that do the best work, like I said before, are often not funded. And that's like a systemic strategy that we need to challenge, or we'll continue to lose folks because of policies. So yeah, and the fact that like the stats are increasing and there's not funding, like that's concerning to me. And people are smoking so much more now. The supply is so dangerous, and people are switching to smoking for like harm reduction, and then we're deterring them by not allowing them to have sites that allow smoking. So I think I really commend Prairie Harm Reduction for all that you've done for people who use drugs. And for blood ties, I think like the drug checking that you mentioned, like that's such an important piece. And the drug checking is not like at the caliber it needs to be yet, but I appreciate the thoughtfulness and also allowing the people who use drugs to identify like their own chill out space and have them guiding the process. I think community engagement and real drug user leadership will be so important as it grows. And I've heard such great things. So I appreciate all your reflections on like the privacy and safety issues. And I really like the tent idea. That's like such an important like piece to adapt to the needs of service users and people who use drugs. So I really appreciate the work that you do as well. So thanks for challenging the system and offering what people need in the face of all these obstacles that come up with opening and operating these spaces while saving the lives of people who use drugs. It's so obvious that we need to rethink some of these policies to adapt to the people who use drugs needs and the drug supply. Funding's a huge challenge, and often in community, it's often on the community to fund what the government should, and that's not fair. So I think you all do great work and I appreciate it so much. Thank you. Oh, and Pam, I think Pam.
Yeah, thanks so much, Ashley, for your insights and your closing words. That's a perfect way to wrap up the discussion. I know it went by really quickly today. There were lots of people really engaged. We only had the lunch hour with a lot to digest, and I'm sorry for the pun with that, but really appreciate everyone's engagement, and thanking all of the presenters, Nat, Casey, Jill, Kayla, and Ashley, Mark as the panel facilitator. In the evaluation, the evaluation link is there in the chat and will be circulated to everyone registered. It's an opportunity to also let us know what you would like to discuss next on this topic or other related topics. And we will also have a resource available with some of the literature and resource documents that people were discussing during the session, and a written summary of some of the key points that were shared, just so that those are available, posted alongside the recording of the session today. So I'll leave it at that, and you can look for past presentations and upcoming presentations as well on the PHO website. Other education and events are there as well. So thanks, everyone. And there's just some information there on the screen about the COMCAP project at Public Health Ontario, and how we're working together across the province with local leaders, and this extends out to others in Canada, like today as well, to have these conversations. On PUD, Nat has listed the website there as well. I know we went a little bit over, but enjoy the rest of your day, and thanks so much, everyone.